a very warm welcome. Emergencies, as they say, are not some things that you can prevent, but certainly things that you can be prepared for. Today, May 27th, being the International Day for Emergency Medicine, we welcome each one of you to this very special panel discussion with the Emergency Medicine Department here at Continental, headed by Dr. Arun. We also have with us Dr. Guru and Reddy, Chairman and Managing Director of Continental Hospitals in Gachibowli, Hyderabad. As I said, today is the International Emergency Medicine Day. So we're going to talk about what exactly is emergency medicine, its different facets, and how emergency medicine is practiced here at Continental. To begin this discussion, I'd like to bring in Dr. Arun, who's the Head of Department of Emergency Medicine. And sir, why don't you start us off by talking about what exactly is emergency medicine?
Emergency medicine is dynamically developing domain in healthcare, which actually deals with acute and critical care of various medical specialties like medicine, surgery, gynecology, orthopedics, and pediatrics. It's quite a new branch to India. It was launched by MCI in 2011, and the curriculum of post-graduation and specialization start from then. Pace of the development in the country and the acute needs of the country, there is a lot of scope in the development of emergency medicine and for the future of India. Emergency medicine has a comprehensive approach of pre-hospital assessment and resuscitation and in-hospital resuscitation and stabilization and post-resuscitation critical care. It is also a domain which works on disaster management as well as public safety measures.
Right. At this point, we'll bring in Dr. Reddy into this discussion. Sir, you started this back in 2013, a state-of-the-art 30-bedded emergency medicine facility, unheard of, definitely in South India. So what exactly was your vision a decade ago for emergency medicine, and how has that evolved?
Okay, thank you, Venus. I think as Arun has just very eloquently described what exactly constitutes emergency medicine, I'd like to slightly expand on that and then take forward with my vision as why we established emergency medicine department at Continental. Now, so just to add on to what is said, in India, for such a large country, emergency medicine as a specialty only evolved in the 21st century. And during my evaluation from the US, where I spent more than 3 decades at that point in time, that came as an extraordinary surprising factor. However, in India, prior to the emergency medicine, they were calling this as casualty. Most of the hospitals did have casualty centers, and they were not really akin to what the Western emergency rooms or emergency facilities were established. So, as I mentioned, it was basically 2009 or 11, the Medical Council of India, the then Medical Council of India, came forward to recognize emergency medicine as a distinct subspecialty, and the first time MD in emergency medicine was started. Then it was roughly over 2013, the National Board of Examiners initiated the DNB course in emergency medicine. In fact, in India, as all of you all know, Dr. Suresh Prabhu was considered to be the father of emergency medicine, and the first emergency medicine hospital in India was established both at CMC Vellore, and along in the public sector. It was CMC Vellore, if I'm not mistaken, I think they said somewhere around 1994. And then thereafter, in the private sector, it happens to be the Sundaram Health Foundation. And the Sundaram Health Foundation, they did this in association with the Long Island Jewish Hospital from New York, which has one of the largest emergency centers. See, what made me really focus on emergency medicine is with my 3+ decades of stay in America and working in leadership in various hospitals, I realized the importance of patient care in an emergency situation or an urgent care situation, and how significantly it changes the journey of a patient when he presents to the hospital. So given that, I said the country should, India as a nation, should really lunge forward in spite of the various resource constrictions that we had or constraints that we had in terms of having physician faculty, in terms of trained nurses, in terms of a properly designed facility an emergency room or facility requires. So with that vision, I had this feeling, a strong conviction in me that no patient in any country or community should die, if he or she has a cardiorespiratory arrest, or he or she is in a trauma, if he or she is involved in an accident, which requires an emergent attention. So with that vision at Continental, we established one of the largest emergency centers, with a 30-bed facility. And not only just establishing a 30-bed facility, but we had the foresight to plan this facility to break it down into various segments, where we have on one side the surgical side of the emergency for trauma and accidents, and we have the medical side of the emergency to take care of a patient who present with acute stroke or a patient with heart attacks and all. And more recently, we added a beautiful pediatric emergency facility so that we don't have to mix the adults and pediatric patients together. So there was an imminent need in the country, and I felt compelled to take this challenge and have the beginnings of a good emergency infrastructure for the community.
Right. So as I said, today being International Day of Emergency Medicine, we also in many ways celebrate a decade of excellence in emergency medicine here at Continental. And as the head of department, Dr. Arun, can you just underline the importance and need for an emergency department in a facility like ours?
So any kind of medical emergency, patients can't wait for an appointment or doesn't come with an appointment to the hospital. So understanding this basic condition, every hospital need to have a strong emergency department to cater to the disease burden of the patients. Taking it forward, whenever there is a patient who is arriving to the emergency department with an acute illness, there is always a pathology which might be a severe or a minor. In general, for a layman perspective, every condition has got 3 E's. One is an entry phase, where second is an establishment phase, and third is an end organ damage phase. So our approach to these 3 E's would be a pre-hospital assessment or in-hospital assessment, prompt resuscitation, prevent the disease progression, and prevent end organ damage. So any hospital which pledges to reduces the disease burden of their patients will definitely have a strong emergency department for the better future of the patient.
Right. Sir, we've come 10 years from inception, and I'm sure both emergency facilities here at Continental and across the country have improved. But with your experience, how do you think we still stack up against the facilities or protocols in the West?
Well, that's a good question, Venus. I think the progress is always made when we learn from someone in life, or when we compare to someone, and then one kind of makes that as a point to improve. Now, just to give a perspective from the statistical point, in America, roughly about 140 million emergency visits are made every year. If you translate that into crores, which is about 14 crores. So in the American perspective, you would take 350 million people, so 1 in 3 is visiting the emergency room in a given year. Or in Indian perspective, it translates to 14 crores, so we can say that roughly about 1 in 10 or something like that, correct? So I always wondered, a country which is already with an evolved medicine, so advanced, and where they have access to doctors, regular visits, and all of these things, they're very conscious about the healthcare. Still, they were needing, this kind of emergency room visits, which only goes to say that patients or the citizens of the Western countries are very sensitive to their healthcare needs. They're not just sitting at home and they're waiting for a catastrophic thing to happen. Out of those numbers which I just mentioned, 30% are usually associated with trauma. Okay. So when we open the emergency room, prior to opening at Continental, I visited some other centers across the country. because I studied the system in India. I have been to hospitals in Mumbai, Delhi, and Chennai, and some of these places. And much to my surprise, I found, in those places where even we have beds of 8 to 10 or 12, most of the time these beds are empty. So that kind of confused me. Either there is not an understanding amongst the public, or what else is going on, or this being a very new specialty, the awareness was not made. But lo and behold, when we started Continental and people looking at our facility and our establishment and our doctors and our nurses and our paramedics and our ambulances that were very ready to reach out and to pick up patients, we started off somewhere about seeing 5 to 6 patients a day, whose numbers increased now to somewhere around, Arun and the rest of the people can correct me if I'm wrong, probably somewhere around 60 to 70 patients a day. That translates roughly about 2,000 and 24,000. The hospitals that I was associated with, the chief of staff in the US, we used to see about 50, 60 to 70,000 patients a year. Okay. So obviously in the Western country, we have, there is a huge trained resource, both in terms of physicians, trained nurses, and trained paramedics. So they have a significant advantage. And we in India were just at the beginning of this, and particularly even to find doctors who are trained in emergency medicine. So in 2013 when Continental was established, but we are lucky enough to have one of the first 1 or 2 batches of MD emergency medicine trained physicians to be at Continental. As a matter of fact, we were the first ones to have an MD emergency medicine doctor to lead Continental, and within very 2 years we also started on a postgraduate program for emergency medicine learning. So succinctly, to give an answer, we are way behind in terms of catching up with the West, but with now more number of doctors who will be graduating with MD emergency medicine. Just Chennai alone has 80 seats this last year. 24 government medical colleges in Chennai or in Tamil Nadu have started MD emergency medicine program. So the vision started up with our politicians, including our Prime Minister Modi, and who himself formed several cabinet subcommittees to look into this, and particularly roadside accidents and trauma and all of those things. So I think shortly within a few years' time, this resource crunch issue will be addressed, and they'll be in much better shape.
Sure. So those are some fascinating insights of emergency medicine emergence development over the last decade. Dr. Arun, before we close this part of the discussion, if you can just tell us about the turnaround times and how we deal with emergencies here at Continental, and then we expand the discussion a little more.
So adding to as Sir said, we have around 60 to 80 step calls every day, and prioritizing according to the need and acuity of the patient is very important. So we follow a triage system called as the START triage, START, which is actually an American triage system used by American Armed Forces. So we have 4 segments. In that, first one is the red segment, where the patient is addressed immediately from 0 to 5 minutes, and where which is actually considered as a life-threatening condition. And the second level is an yellow segment, where the patient is near to 0 to 10 minutes. And the patients coming under the green category are stable patients, which can be addressed in a time span of 0 to 15 minutes. And we have a blue category, wherein they are expectant patients, or mostly the outpatients, which are categorized into it. So accordingly, we have a timeline for these the patients coming into the ER, and we have dedicated nursing as well as the doctors for that areas particularly, and we triage them accordingly and treat them as per the need and the requirement.
Right. So friends, as we started this discussion talking about emergency medicine, we focused primarily on what is emergency medicine's different facets. Now we segue into taking it on a broader scale. We try and understand different kinds of emergencies that we face on a day-to-day basis. And we have with us the team of emergency medicine specialists, Dr. Sindhoora, there is Dr. Pradeep and Dr. Ravi, Teja, and we'll bring them into the discussion as we move into the next segment, which is on medical emergencies. And once again, I'll start it off with Dr. Arun and then we'll bring in the rest. So Dr. Arun, what are medical emergencies now?
Any emergency which is not under the capacity or a containment of an individual, any medical condition varying from a small pain to an injury can be considered as a medical emergency. For example, I'll try to take in a condition of a simple headache. A headache varying from a score of 0 to 5 out of 10 can be a bearable pain, and the pathology behind it could be minor pathology. Whereas a headache ranging beyond 6 to 10 pain scale can always have a major pathology behind it, like a bleed, or it could be some kind of an infection, meningitis, and there are n number of reasons for it. So, not really correlate with the presentation of the symptom, or does not have a directly proportional relation to the pathophysiology. So it's always better to understand a patient's capacity to contain or bear the condition, and take a medical advice as soon as possible is always advisable.
Right. So as somebody said, we are all products of the environment that we are in. So Dr. Pradeep, if I can bring you into the conversation. So can you help us understand, are there environmental factors around us which can contribute to medical emergencies?
Hello everyone, thank you Venus at last. As we're in the peak summers in the May season and the temperatures are soaring high, we are expecting or we encounter conditions called heat exhaustion and heat stroke. Heat exhaustion is a minor form of the symptoms, and heat stroke is the severe form of the condition. So in heat exhaustion, we can see symptoms presenting with mild headache, increased thirst, sweating, some nausea and vomiting. But when we go to heat stroke, the patients can have severe symptoms like confusion, delirium, even unconsciousness, and sometimes even death. So prompt assessment and prompt treatment of these conditions is important to save the life of the patient. So always whenever you notice any patient with these symptoms, please get them to the emergency department so that we can take care of the patient. And once we move forward from summer season into the rainy and winter seasons, we encounter more of symptoms with breathing difficulty. Patients can present with breathing difficulty whenever they get exposed to the cold weather, when they get exposed to the pollen grains, they can present with breathing difficulty. And patients having asthma, they can have acute asthma attacks. So we need to be wary about the environmental conditions.
Right. So while we talk about environmental factors being external, there are a lot of things we do to ourselves. There are lifestyle choices which we make on a day-to-day basis to understand how our lifestyle choices can sometimes lead to emergencies. We have Dr. Sindhoora who will throw some light on this particular aspect.
We keep encountering a lot of patients, that too young individuals, walking into the emergency room with a wide variety of complaints like headache, dizziness, chest discomfort, breathing difficulty, and many such things. And most of the times it is seen that 80% of these individuals walk out with the diagnosis of anxiety. It is that common. Anxiety is so common these days, and anxiety is nothing but the body's natural response to stress. The stress hormones, when released inside our body, will cause the heart to beat more faster, and the hormones also will result in narrowing of the blood vessels, thereby rising the blood pressure. So this anxiety-induced rise in blood pressure is usually transient, but frequent anxiety episodes and long-term anxiety can by itself have a lot of adverse effects on the vital organs, just like how hypertension or diabetes can cause. And there are all these substances that people use and keep coming to us, and we at Continental are well equipped and have all the expertise in treating all the conditions related to lifestyle emergencies.
Right. Dr. Arun, Dr. Sindhoora just mentioned diabetes. So if you can take that and expand how a lifestyle condition like diabetes could be contributing to a medical emergency.
Diabetes is a very common lifestyle condition. It's a very common in young patients as well as in the older patients. Basic pathophysiology behind the diabetes is uncontrolled sugar, either because of the deprived insulin or either because of the dysfunctional metabolism of the sugar inside the body. So the problems vary from either an hyperglycemia or due to an hypoglycemia. Hyperglycemia is a condition where the sugar levels in the blood are quite high. When the sugar levels in the blood are high, the stress hormones which are released in the body, and we have a chronic effect on the vital organs, resulting in the form of diabetic nephropathy, diabetic retinopathy, and etc. And the same format, they also have an the general metabolism of the body, and there's a condition called a diabetic ketoacidosis, where the glucose in the body is not utilized, but the fats in the body are being break down, and the patient turn into ketosis. This is a life-threatening condition wherein most of the elderly patients present to the emergency department. Coming to the hypoglycemic side, wherein the low glucose levels are usually because of some kind of a drug abuse, or it could be because of, so maybe the patient sometimes uses the drug but doesn't have taken adequate food, have a fall in the glucose levels, which affects the brain and usually present in a comatose state to the emergency department. So, but nevertheless, diabetes, even though it's a very common disease, there is always a risk factors, the chronic as well as an acute functions. So, patients who are already suffering with diabetes should also look for the life-threatening conditions like diabetic ketoacidosis and also and hypoglycemia.
Dr. Ravi, if I can bring you into the conversation. Dr. Arun was talking about drug overdoses, reactions, and so on. So allergies, these are very common emergency situations that we deal with. Can you help us understand, what exactly are these, and how do you deal with these here at Continental?
Yes, Venus. Talking about other medical emergencies, one of the frequently medical emergencies we encounter is the anaphylaxis. Anaphylaxis is nothing but an immunological response to certain type of drugs, or it could be a food substance, or it could be some bee stings, or it could be some other chemical substance, it could be anything. So what happens in these conditions, usually it starts with the usual rash with itching, which gradually progresses into severe symptoms like breathing difficulty and swelling of the lips and tongues, obstructing the airway. And sometimes even they might progress into the shock condition as well, which requires an immediate medical attention, otherwise the valuable life would be lost. And talking about the other things like the drug overdose, what we mentioned, and one of the frequent things we see in this segment is the toxicology, where majority of the cases comes with the history of poisoning or consume of some other substances, and sometimes unknowing substances without any proper history. So toxicology is one of the main segment in the emergency department which requires immediate attention. Otherwise, we can see more fatality in this segment.
Sure. One of the main emergencies that I usually encountered while I was in school to get out of a class was stomachache. And we have with us a very renowned gastroenterologist. So it would be remiss of me not to ask him about gastroenterological emergencies, not my stomachache.
Good question, Venus, as Dr. Sindhoora has very nicely pointed out and dwelled upon the aspect of anxiety. Okay, so that segues into another section of medical disorders, what we call as functional medical disorders. So many times, the complaints of abdominal pain, pain in the chest, or sometimes, shortness of breath, these kind of issues are very commonly presented to the emergency room. That's when Dr. Arun has very eloquently highlighted the function of triage. The triage is extremely important. So there are three types of triage from my perspective. One is what we call as an immediate triage, an urgent triage, and the last one is, semi-urgent triage. Now, what does a triage mean? Triage means an initial evaluation of the patient, and particularly that happens by a nurse. Now, when you're doing the triage, why I was mentioning about triage is that within a span of 1 to 3 or 4 minutes, typically this is the standard timings for a triage. The nurse or whoever is triaging the patient basically is supposed to gather the information with regards to the physical well-being of the person, with the symptomatic issues of the person, with the emotional and social issues of the person. So all of this in a span of 4 minutes. So if we have a good triage functioning in an institution, in a good emergency room as we have at Continental, then the doctor's participation and everything else becomes very easy. Because not all abdominal pains are necessarily emergent, okay? Not all abdominal pains are necessarily acute, and not all abdominal pains are necessarily warrant, expensive and extensive evaluation. So it is the competence of the doctor, it is the competence of the triaging nurse, it's a history taking that we quickly segregate and classify these patients, between really emergent, urgent, non-urgent, and accordingly proceed on to investigate these patients.
Sure.
But don't mistake that we cannot just be light-hearted about these things,
Right.
because you have to be on top in terms of how you distinguish your patients, because we don't want to miss, a real pathology saying that this patient is anxious and there's nothing to it. Okay.
Sir, if you could also briefly touch on foreign body injections, something consumed, food poisoning, because nowadays it's the lifestyle to eat out, eat at irregular hours. So how about those things?
That's a good question. At Continental, we see a lot of patients which are usually children with foreign body injection. And in the rest of the world also, in pediatric emergencies, because children tend to swallow things, without proper attention. So we see children who are swallowing batteries because they're constantly playing with various toys and things like that. They might be swallowing needles, they might be swallowing some caps, or bottle caps and so little metal objects. So these are all considered to be foreign bodies. And when such a thing happens, when the child comes, to the emergency room, a quick attention is required, because the doctor is evaluating, decides whether there's an emergent intervention required after certain diagnostic tests, whether you need to call a gastroenterologist like me, or whether you should call an ENT specialist, whether that should be removed right away, or we can just wait and follow the patient. So these are all the decisions that are made, but nevertheless, it requires attention. Now coming to the adults, foreign bodies in adults in India are very uncommon. In the Western world, we used to see foreign bodies, usually from meat impactions. Because the Western diet is different, people are used to eating, steak and, burgers and all of these things. And, I spend a fair bit of time in the middle of the nights, going to the emergency rooms, and being on call, fishing out the steaks. And I used to make a joke, this was the most expensive steak in the world, because by the time the patient got the bill, would have been several $1,000s. And so, in Indian perspective, a foreign body thing is a little less common, but sometimes we see patients who have excess alcohol and who are intoxicated and who are not sure, what is accidentally swallowed, and these kind of things can happen. But the moral of the story is that pediatric foreign body impactions are very common. They should go to the right place. They should go to a place where you have entire armamentarium of appropriate consultants and specialists, and your operation theatre should be functioning 24/7. Your anesthesiologist should be available to participate and help retrieving the foreign body.
Sure. So friends, as I was listening to Dr. Reddy talk about the triaging system, I think the motto of the emergency department is keep calm and carry on. And we do that every day here at Continental. On this World Emergency Medicine Day, we are having a conversation with our emergency department, as well as Dr. Guru and Reddy, the chairman and managing director here at Continental. So from talking about medical and functional emergencies, we move on now to a few organ-specific emergencies, and one of the very common emergency that all of us, I'm sure at some point of time have been witness to, is stroke. So Dr. Sindhoora, if we can talk about what exactly is a stroke, how do you define it, and what are its various facets?
Well, before I even get into it, I would like to clarify that I've heard a lot of my relatives, elders use the word stroke in a very different way. I'm sure all of us must have heard someone saying, my father had a heart stroke. That is a misnomer. Stroke is nothing to do with the heart. It's always a heart attack, and stroke is always to do with the brain. So it's the brain stroke whenever it's said as stroke. So let us just understand basically what brain stroke means. Brain stroke can be of two different types majorly. One is called the ischemic stroke and another is called the hemorrhagic stroke. So when it comes to the ischemic stroke, it means that the blood vessels which are supplying the brain are either narrowed or there is a block in the blood vessel causing some disruption in the oxygen supply or the nutrient supply to some part of the brain. This is the ischemic stroke. And when it comes to hemorrhagic stroke, it is nothing but the bleeding into or within the brain. And this thereby again disrupts the oxygen and nutrient supply to the brain vessels, brain cells. And it's not at all an exaggeration to tell you that just within a minute of time, we tend to lose around 12 millions of brain cells if left untreated. So time is brain, and treating at the earliest is how we help the patient to gain his functionality and lead a better life. So before my team members can emphasize more on this, I would like to tell you all something about something that all of us can do, not just medicos. Anybody can, for that matter, can recognize a patient with stroke if they know something called as FAST. FAST is an acronym, F-A-S-T. F stands for facial drooping. Whenever you see someone beside you going through some sort of a discomfort or is unable to talk or something, the first thing that you have to observe is if his or her face is drooping. Ask the patient to speak or say E or smile and observe if the face is drooping. And the alphabet A in the FAST, the next alphabet A stands for arm drifting. Ask the individual to raise his or her arms, and if one of those arms is drifting or if the victim is not able to lift his arm, then it means that it is an arm drift. And the alphabet S stands for slurring of speech. Ask the individual to frame a sentence or a phrase and see if there is any slurring of speech. And if any of these three things are there, do not delay any further to talk to the doctor, because the earlier you take the patient to the doctor, the sooner the treatment, the better the outcome.
Right.
So it is the window period in which our emergency physicians act wisely, which will help in better outcome of the patients.
Right. So as I understand, time is of the most important essence here. Dr. Ravi, can you elaborate on this particular aspect of window time as?
Yeah, like Dr. Sindhoora has emphasized, time is brain. So it is the most important segment in treating the stroke. So there is a concept called as window period. It's the time from the onset of the symptoms, from the 0th minute to the time we insert the needle and give some drug called as a thrombolytic drug. So that certain period we consider it as a window period. So in the span of within 4.5 hours, so we need to be able to identify the patient's symptoms and need to get the quick evaluation done and give the appropriate treatment necessary. Right. So because why this is so crucial is because for every minute delay there will be millions of neurons lost, and for every 1 hour delay there is a 3.5 years of quality life is lost. Right. So this is in terms of IV treatment relating to the drug. If the patient presents beyond the 4.5 hours time limit, we have another segment called as mechanical thrombectomy, where we can extend our treatment segment up to the 6 hours, where the subsequent specialties like interventional radiologist along with the neurologist will be involved and can be taken up for the thrombectomy procedure, mechanical thrombectomy, that can be extended up to the 6 hours. So this is the window period what it signifies.
Dr. Arun, with so much emphasis on time and early intervention, can you help us understand how prepared are we here at Continental to deal with the strokes and make sure the time frame is taken care of?
Yeah. So Continental Hospital has got a quaternary stroke unit wherein we have an integrated approach of a stroke team, which is led by an emergency physician, neurophysician, neurosurgeon, radiologist, and a interventional radiologist. So as my team was saying, brain is time. Everything has to run against the time during the time of stroke. The window period is usually 4.5 hours. But the stroke, as we said, there is an ischemic stroke and also the bleed in the brain is also considered as a stroke. So first, an evaluation of the patient, primary resuscitation of the patient, followed by a diagnostic play a major role in the first 20 minutes. Followed by a diagnosis in terms of a bleed or an ischemia plays a vital role. And if you found to be an ischemia, there is a method of thrombolizing the patient, whereas the clot is burst through an injection, or if at all the patient passes beyond the window period and still has a chance, the clot removal is called a mechanical thrombectomy by an interventional radiologist and also a neurosurgeon. So this is aligned through a stroke code, which is announced as soon as the patient comes into the emergency department, and all the doctors are alerted and everybody is on work in their own domains by stopping the disease progression and preserving the quality of life.
Right. So Dr. Arun gave us a larger or broader overview. I'm going to go to Dr. Pradeep to really focus in on how things happen the moment you have a patient at your ER door.
Yes, Venus. Whenever a patient steps into the ER, we immediately evaluate him, triage, evaluate him, and once we evaluate him, we will know what type of stroke it is, if it's a hemorrhagic stroke or a ischemic stroke. In the ischemic stroke, we have a time called door-to-needle time. So the door-to-needle time represents the time the patient comes into ER till the time we give the thrombolytic agent. So as per the international standards, the door-to-needle time is around 60 minutes and not more than that. But here at our Continental Hospital, because of the extensive stroke unit we have, we were able to achieve the door-to-needle time as less as 40 minutes. Within 40 minutes, we could evaluate the patient, we could take him to a scan, see if it's a hemorrhagic stroke or ischemic stroke. Once it is ischemic stroke, we were able to thrombolize him within 40 minutes. And it's a great achievement, I think. And as per the statistics, in the last 10 years, we were able to thrombolize more than 500 patients in the emergency department, and it's a great achievement.
Fascinating. So now you've heard those numbers. So how do these numbers stack up against what is in the West, and how further do you think we need to improve on those to really come up to the Western standards of emergency medicine?
Now, firstly, let me just congratulate the team here, and each one of them so eloquently narrated and described what exactly is stroke from the get-go of its definition. Because it's very important for, from the layman's perspective, to really have this understanding. So the next time he or she or somebody in the neighborhood or a friend or a relative, encounters this, that they're ready to take the next step and action. So, and most importantly for us all to understand the classification of the times, which is the golden hour, and followed by the first 4.5 hours, and post that, what are the procedures, that are done. We are very proud at Continental. I believe that, I do not have this, clear statistics, but what we have been told many times, and from the recovery of patients, and the compliments, and the feedback that they've given, and the fact that, we have prevented, permanent injury to these patients by this fast action, as what Dr. Pradeep has just mentioned, is something very commendable. So here at Continental, we have everything set up, and many times I feel, as I still travel between the US and here, and seeing for 4 decades what the Western emergency rooms and the stroke units that originated there, and we have kind of emulated them. We are no less than perhaps any other international medical facility in terms of a stroke unit. Our vision of establishing a stroke unit dates back to almost 8 years or 9 years, prior to today. And at every level, this was used as a quality indicator, including our Joint Commission certification, National Accreditation Board certification, and we're always applauded for that. So what really kind of in a nutshell makes a difference to run a very successful stroke unit at the end of the day, as Dr. Arun has narrated, number 1 is establishing the unit, number 2 is establishing the protocols, number 3, make sure we have the complete bandwidth of the appropriate specialists, which is essentially the emergency room physicians, the neurologists or the neurophysicians, the neurosurgeons, the neurointerventional radiologists, and sometimes the neurosurgical interventional radiologists, and who are available 24/7, for that intervention. We are fortunate at Continental at all times that such facilities are available. I do not remember of a single incident thus far. I can say this very proudly that we have to turn away a patient or we were not able to treat promptly because there was a deficit in one of these things. So in contrast to the Western world, Venus, as you clearly asked, in this particular arena or this particular area, I feel that we are probably superior to many, and I say that with the greatest pride, and thanks to the entire team.
Right. So then, those are some fascinating numbers that we heard and facts that are before us here at Continental. For every stroke emergency, we are in preparedness. So as Dr. Sindhoora was talking, strokes are all about the mind. So now we'll get into the heart of the matter and talk about some cardiac emergencies. So, Dr.
Just to interrupt, I'm sorry to interrupt you. One of the important facts we forgot to mention, what is the epidemiology of stroke? Every 1 in 3, in the country or in our nation is expected to develop a stroke if not properly taken. So there is a huge burden that is coming our way in terms of patients who will be presenting to our emergency rooms or hospitals. Hence, the kind of preparedness that we have at Continental or other hospitals, or other healthcare facilities should gear up to that, because the burden will be enormous.
Right. So this is just not about what is happening at Continental. We actually envisage a much improved emergency medicine paradigm in the country in the days and years to come. Dr. Arun, as I was coming back to you, is every chest pain a medical emergency to be dealt with?
Yes, Venus, the chest pain is usually a very common presentation to the emergency department. It caters to around 15 to 18% of the patients every year to emergency department. But chest has got quite a number of organs which have the same nerve supply or pain fibers which map into the parietal lobe of the brain. So the presentation of each organ might vary. So understanding the pathophysiology behind every chest pain is very important. So it has got two aspects. Not every chest pain is related to heart and life-threatening, but at the same time, the second point is every chest pain can't be neglected. So it's always important to get it evaluated for every chest pain, depending upon irrespective of the pathophysiology and depending upon, not depending on the age or the other comorbidities. So lastly, in the recent trends, we have seen that a lot of young people coming up with chest pain and crashing in ER because of an acute MI or acute heart attacks. This could be because of the many reasons, and it has been a misnomer in the past that like the chest pains are not heart attacks in young. But please remember, not every chest pain could be an GERD in terms of an acidity related issue or a gastric issue, or it could not be just a muscle or a bone related issue, or it could not be something else. It could be what we are being afraid of. So please always do get yourself checked and have a certainty of life.
Right. Dr. Pradeep, Dr. Arun was talking about heart attacks. Now, Dr. Sindhoora also made that distinction between strokes and heart attacks. So, can you dwell a little bit on the aspect of heart attack and explain that a little for our audience?
Yeah, definitely, Venus. And in simple terms, I would like to tell about heart attacks or myocardial infarctions in medical terminology. So basically, whenever the blood vessels supplying the heart are blocked because of a clot, then there is a disruption of blood flow to that part of the heart muscle. So then the area or the heart muscle gets injured or can go into permanent damage, causing a heart attack. So whenever you have these heart attacks, the patient should, or the people should always look for these signs like left-sided chest pain, pain radiating to your left shoulder or to your left arm, sweating, breathing difficulty, nausea, vomiting, dizziness, palpitations. If you notice any of these signs and symptoms, please come to the emergency department immediately. Do not waste any time. And please do not, as like Dr. Arun had said, do not confuse with gastritis. Don't think that it is gastritis. Chest pain should be evaluated by a properly trained doctor. So you have to differentiate whether it is a heart attack or gastritis. So let us do that for you.
Right.
And whenever you have a heart attack in the ER, what we generally do is, once we diagnose them to have a heart attack, we give certain medicines called loading doses with ecosprin and clopidogrel and atorvastatin. Those are antiplatelet and anti-cholesterol medicines. And we prepare them for an angiogram. The cardiologist in the cath lab does a procedure called angiogram, where they put a catheter into the heart and see where the blocks are. Once they diagnose the blocks, they can put a stent to improve the blood supply, to bring back the blood supply, and that procedure is called angioplasty. And at our hospital, we have 24/7 cardiologists available with cath lab facilities, anesthetists, everyone is available so that we can achieve greater success in rescuing the patient. And there is another terminology in the heart attacks where there is door to balloon time. So when the patient comes or walks into ER, from that time, the patient undergoes an angiogram and stenting. That is called door to balloon time. Again, the international standards say it should be within 90 minutes. Again, I'm really proud to say that at Continental, we were able to achieve that door to balloon time within 60 minutes because of the team. It's a team effort. I would definitely say it's a team effort, and it's a great success, I would say.
I'm pretty sure if we are 2/3 of what the Western countries are able to do, then definitely something for us to be proud of. Now, other than chest pain, of course, one of the common cardiac symptoms is your palpable heartbeat, or your heartbeat going really fast. And Dr. Sindhoora was talking about the anxiety element. So, ma'am, can you kind of demystify these things for us?
Our heart beats with a particular rate and a particular rhythm. Rate is the number of times that the heart beats, and rhythm is the particular fashion or the pattern with which it beats. So any disturbance in either of it, right? If there's any disturbance in the rate or the rhythm, that particular condition is called arrhythmia. Arrhythmias can present to the emergency room in a wide variety of symptoms. It can range from a simple lightheadedness, dizziness, to feeling of one's own heartbeat, which is called palpitations, to the worst scenario of a sudden cardiac death. At this point, I would like to emphasize on a recent case that we have had, that there was a young individual who was just a 24 years old male who came to us with no pulse and no BP being recordable. And he was resuscitated promptly in our emergency room, and on evaluation he was found to have this congenital heart problem, and in those patients, particularly in the young individuals who will have a chest discomfort, and in them, if there is any congenital heart defect, then in them arrhythmia is the reason for death. And so, the moment a patient comes to us with palpitations or any symptoms related to arrhythmias, it can happen transiently, or it can be there overt at the time of presentation. And we at Emergency in Continental are very well equipped with all the medications that can immediately revert the rate and rhythm back to normal. And despite these medications, there are cases who do not respond much, and in them there is a requirement of something more called as the definitive treatment for arrhythmias, which is nothing but the defibrillators or the pacemaker insertions, and all of that have been done very well on time, saving a lot of young individuals suffering arrhythmias in our hospital.
Right. So in the triad of strokes, we also heard about attacks. Now let's go to heart failure. So Dr. Ravi, if you can help us understand what exactly is heart failure, how is it different from a heart attack?
So speaking about heart failure, it's not as so uncommon that we frequently see on day-to-day basis, particularly in elderly patients, because the majority of the elderly patients with the previous heart disease, they usually present with this state called as heart failure. Heart failure is nothing but the weakening of the heart and failure to do its normal function. The normal function of the heart is to pump the blood throughout the body, and the failure of the heart to do its own work, we term it as a heart failure. So the main reason for this heart failure is because of the underlying underlying conditions like previously what has been emphasized, like heart attacks or previous valve problems, sometimes infections like myocarditis, or sometimes blood collection around the heart, or sometimes blood clots within the lungs, we call it as pulmonary embolism. All these things can precipitate into the heart failure. Once the heart failure is progressed, means like it's for the long time, it can even we call it as a chronic heart failure, and usually these patients present with swelling of the limbs, swelling of the body, swelling of the face, breathing difficulty, increased heart rate, and sometimes drowsiness, and sometimes even in unconscious states. So all this requires immediate medical attention, and proper assessment and proper treatment need to be given for them. And sometimes assisting devices can also be planned for people who are not responding to the medications that will be done by the cardiothoracic surgeons along with the cardiologist at the Continental Hospital. So ultimately requires apt response so that the valuable life can be saved.
Right. Sir, Dr. Guru, as a healthcare visionary now, we see India as a growing population, a young population, and cardiac diseases are on the rise, and then you hear numbers like, we are beating the Western standards 2 to 3. So how does that make you feel, and how prepared are we for the emerging cardiac emergencies of the future?
Yes, I think it again, relates to the fact, what kind of a healthcare establishment a particular community has. Certainly in a resurgent India, we have seen growing number of hospitals and growing number of healthcare facilities, and also both in the public sector and private sector. So the key here is that how one plans is extremely important. As we said, emergency medicine is very novel in this country and novel to lots of physicians. It's barely a little over a decade old. So given this paradigm, the new hospitals, the new facilities that are planned, they should follow these guidelines, well-established guidelines in taking care of these patients when they present to the emergency room. So we have to go a very long way, because we have many issues in our country. We have the rural-urban divide at the end of the day. We have a socio-economic divide. We have issues of affordability, and we have issues of still, I think, well-trained doctors and nurses. We have issues of equipment and all of those things. So the most important thing, we have to convey the message to the public is that, or the most disastrous thing that can happen, claiming yourself to be an emergency room, or claiming yourself to have facilities in your institution that you can take care of these patients, but unfortunately not rising up to the occasion, is doing tremendous disservice, and this almost can be criminal at the end of the day. So just having an emergency room and just saying that we're able to do an EKG for this patient, but not having a cardiologist on board, or a cardiologist not willing to come to the emergency room to the so-called the window period that a patient can be salvaged, or a hospital does not have a cath lab or necessary equipment. All of these things matter. So just declaring to the world that we are equipped, we have a hospital, which is somewhat of a fashion in our country at the end of the day, because the licensing, the regulation, the statutory oversight, there is a huge lack. There's a tremendous gap.
Right.
Unless and until these issues are solved, from the standpoint of a public issue or some matter, we will not be able to address this, very quickly. But I still see many bright spots.
Right.
I think there are many hospitals, I think like Continental, perhaps across the country, who have the vision and the foresight, who are conscious enough that what it requires to constitute, a good emergency center in taking care of its patients, will be happening.
Sure. So as Dr. Guru talks about, Continental, I would like to stress upon the fact that when he talks about vision, he had this vision back 10 years ago, and then now we are seeing 10 years later some of the fruits in front of us. Some of the times that the consultants have been talking about are truly magnificent in every way. I mean, even the Western standards don't match up to those. So we spoke about strokes, we spoke about cardiac diseases. Now we'll talk about something which is very, very common, especially in a location like ours. We sit right next to the ORR. So road traffic accidents are dime a dozen almost on a day-to-day basis. So we'll talk about trauma, road traffic accidents and so on. So Dr. Arun, why don't I start it off with you? Can you help us understand what is a trauma center and what are the features of the trauma center here at Continental?
At Continental, we have a level 1 trauma center. The level 1 trauma center defines as providing end-to-end care, that is from resuscitation to rehabilitation. Basically, every trauma center needs to have a comprehensive team of trauma, wherein it is led by an emergency physician, followed by a group of surgeons and orthopedicians, neurosurgeons, OMFS surgeons, as well as supported by a critical care as well as a standard blood center. So everything should be aligned in a fashion wherein there is no seepage of time. Because in trauma, we are working in the golden hour where every minute loss is actually measuring the life over there. So aligning everybody in the form of starting from the resuscitation. Actually, it starts from the pre-hospital. Pre-hospital plays a very vital role in the trauma, and the resuscitation from the pre-hospital to the in-hospital resuscitation and stabilization to diagnostics, complex surgeries, and post-complex surgery stabilization and the critical care plays a very vital role. So we do have a very strong team of trauma in here in Continental Hospitals, and we cater to any kind of trauma which comes to the hospital.
Right. So Dr. Sindhoora, Dr. Arun talked about the essence of time, how each minute is critical to the life of a patient. So can you talk about how loss of time could eventually lead to loss of life?
Accidents, particularly the road traffic accidents, are not said to be happened. They are caused, and India stands rank 1 among 199 countries to be the largest number of deaths related to road traffic accidents. And in road traffic accidents, many of the young individuals who are the breadwinners of the family lose their life. They might not lose the life right away, but it could be 2 weeks or 3 days or a few weeks later on. But that is because of the irreparable damage that has happened to them in the golden hour. When I say golden hour, it is the first 60 minutes of the time immediately after the critical injury that a victim goes through in a road traffic accident. And it is this golden period that we all work upon, and if intervened aptly and rightly in this golden hour of trauma, then the outcome of the patient can be far better than what we are seeing these days.
Right. Dr. Ravi, to improve upon the patient outcomes in these road traffic accident trauma cases, Dr. Arun also spoke about pre-hospital preparedness or pre-hospital care. So how is Continental geared up for that you are taking care of a patient not just once they reach the hospital, but from the place of the incidents?
Yeah, good. So, like we said, the golden hour, it plays a crucial role in the management and the saving of the precious life. So, what exactly is that golden period the madam has emphasized? So, coming to the pre-hospital care, it starts with the EMT staff, emergency medical services. Once we get a call that so-and-so accident happened at so-and-so place, the immediate dispatch of ACLS ambulance to the certain spot will be sent without any delay, along with the technician, sometimes if required a doctor as well. So, upon entering that scene, the emergency technician quickly evaluates, or a doctor evaluates the patient. So the first 10 minutes of assessment, we call it as a platinum 10 within the first golden hour period. The first 10 minutes plays a crucial role. Within the first minute, they quickly evaluate the patient and do a primary survey. Once it is done, in the next, they spend the 5 minutes in stabilizing and resuscitation of the patient, and the next 4 minutes, they immobilize the patient and do the transport to the hospital. This crucial 10 minutes plays an important role in that first golden hour period. Once within the golden period, when the patient is brought to the emergency, a quick triage and quick reassessment is done, taking the patient into the trauma bay, and the trauma protocol is activating the trauma team as well. From there, the things go on.
Dr. Pete, you helped us understand how different we are in terms of stroke management, in terms of cardiac management. Would you have something to say about how different we are as a trauma center compared to those around us?
Definitely, Venus. Like Dr. Arun had said, ours is a level 1 trauma center. Level 1 is the highest level of trauma preparedness center. So at our hospital, we have a great team in the hospital to cater all the needs. The polytrauma, there is a polytrauma code where we activate a polytrauma code when the patient comes. And the team has all ER physicians, neurosurgeons, orthopedic surgeons, oromaxillofacial surgeons. We have a gastrosurgeons, CTVS surgeons, and vascular surgeons. We have 24/7 blood bank availability, radiologists available 24/7. The consultants, anesthesiologists are available. If the patient requires any immediate OT procedures or surgeries, everything will be done. And we have a great thing going on in the Continental Hospital, thanks to our chairman, Dr. Guru and Reddy sir, that any patient walking into the emergency room with trauma, without any consideration of financial status of the patient, we treat them. We do the investigations, including the CT scan, CT polytrauma scan, and we save them from life-threatening and limb-threatening emergencies at free of cost. This is it's a great achievement for us, even in the trauma field.
Seems like act first, talk later.
Definitely, yes.
All right, sir. Now coming to you. Again, 10-15 years ago, when you were thinking about a healthcare facility here in India, none of these were actually in place. We were still dealing with things like casualty and those kind of stuff. So what made you think so far ahead of time that we need to have a level 1 trauma center in a place like Hyderabad, and how that thought has evolved over the years?
It's a very good question, but my answer will be very selfish and very interesting, Venus. I think when I kind of decided for the hospital, I was personally concerned about myself. I said, what if I'm involved in an accident at the end of the day? Where in the city I should be able to go or take me?
Right.
And I have a family, my children were abroad, and I left my family to do what I did as Continental Hospitals on this journey. So truly there was a selfish motivation. And that selfish motivation was complemented by my more than 3 decades of close involvement with accident and trauma in the United States.
Right.
Like I come from, I've been in Texas and one of the largest medical centers in the world. And as a chief of staff and president of hospitals over the years, I've learned, the classification of the trauma centers and how these things were managed and handled. I'm sure many of you were watching this, ER, the famous TV show, which provides an ample proof as to how trauma and emergency accidents are handled in the West. So I felt there's absolutely a compelling need. I've not seen then, in 2013 when Continental Hospital opened and 2 years prior to that, a single place in the city. I'm not very familiar with the public hospitals, but I think a single center or place in the city which was geared or organized, to take care of in a true spirit. Okay, let me classify. They might be geared, but in a true spirit to provide the right and appropriate care and a timely care to help and salvage. See, doing something is not necessarily the right act at the end of the day. Doing something with the intention of knowledge, with the intention to salvage, with the intention to save a life is the utmost call for any physician. So we said, with all my experience from the West, that what constitutes a level 1 trauma. And we put in all the consultants here, right from the get-go. In 2013, we had 20 specialties, and now we have grown to 50 specialties. And we had this cardinal rule. Many times what happens even into the West, doctors are on call, but they don't show up, they don't respond. So with my experience, and with the consent of many of my colleagues and the faculty members of Continental, with their acceptance, we instituted a rule. If a consultant does not show up within less than 30 minutes, immediately the emergency room physicians are empowered to reach out to the next consultant in the line so that the patient's life is not jeopardized. And that rule till today still is operational at Continental. So as all of the colleagues have very eloquently highlighted, on the aspect of time and timely intervention to salvage a life. And so in trauma place, I think one should be geared towards, otherwise don't accept the trauma.
Right.
Just resuscitate the patient and send them to a facility where that care can be provided. So it's extremely important of the human resource and your 24/7 of all the things that they have alluded to be available in order to declare yourself to be a level 1 trauma center.
Sure. All right, friends, on this World Emergency Medicine Day, we are having a discussion on various facets of emergency medicine, and we've had a long one straddling across medical, functional, cardiac strokes, and so on and so forth. So as we segue into the next segment, those of you who have young children, or those of you who are recently parents, I'm sure you will agree with this, that everything that your child does is an event. At the same time, on the negative side, everything that happens to your child might look like an emergency. So we have a Pediatric Emergency Center here at Continental. So I'd like Dr. Sindhoora to open this discussion. What are the common pediatric emergencies, and also touch upon what are not pediatric emergencies?
Very rightly said. As a mother of a toddler, I understand how disheartening it is to see a kid in pain. And if it is an adult, he will be able to express or tell you what he is undergoing and what is the amount of pain that he has. Whereas if it is a kid or a toddler, he won't be able to do the same. And that is where your expertise lies. And many of the times we see anxious parents walking into the emergency room along with their kids with the history of fever for a couple of days or fever for one day and all of that. I definitely understand. Even 1 hour of fever will definitely make the parents very anxious. So when they come to the emergency, we don't just treat the condition, like we don't just treat the fever, but also explain, make the parents understand that there are those subtle warning signs which we all should look for in a kid. Like it so recently happened that we happened to see a 4-year-old kid who had a history of fever for one day, and that's it. He came to the ER, and we educated the parents that whenever the fever goes above a certain degree of temperature, that is when you have to be extra vigilant in treating or getting him to the hospital and all that. And we also explained to her that just a small sign of excessive blinking of eyes is something that you have to keep observing, because in kids around 5 years of age, till 5 years of age, there's this thing called febrile convulsions, that is the fits or the seizures which happen to a kid when the fever goes too high, when the temperature goes too high. So the premonitory symptom or the warning sign of it itself can be excessive blinking of the eye. And she rightly identified that particular warning sign. She got the kid to the emergency room, and right after he was brought into the emergency room, he threw a febrile convulsion in front of our eyes. But because she was with us on the right time, we could save the kid so properly that he walked out of the hospital just within a couple of days. So febrile seizures is something which is very common in kids these days. It can be self-limiting, but it can also be life-threatening sometimes. We at Continental have had very good experiences of treating all the kids with febrile convulsions on time, and we've helped a lot of kids recover very fast and get back to their normal playful and joyful time. And as Sir rightly said, there are a lot of kids who come to us with foreign body ingestions and foreign bodies in the nose and all of that. And yes, definitely attending to them on the right time will definitely result in better outcome with no much complications in kids.
Sure. Dr. Ravi, foreign body incisions, again a favorite pastime of children. I don't know. They might do it for fun. But how do you, deal with those cases? And how should parents deal with those patients or rather children in the immediate aftermath of something going into their body?
Yeah, talking about in the pediatric segment, we see it on daily basis, the foreign body insertion. Sometimes it might be in the nose and sometimes it might be in the ears and sometimes it might be swallowed. So the first two things within the nose and the ears, even though they are not life-threatening, but yet times they can be depending upon the size and what type of object it has been inserted. So at times it will be difficult to gain the history from the parents because the patient is, the kid is unwell and is not taking orally and he's behaving a little not like a normal. But in majority of the scenarios, the things will be witnessed, but in certain cases we'll have unwitnessed child with some ingestions. So those cases becomes little challenging in treat because if you don't get a proper history, we need to evaluate little further depending upon the radiological investigations as such. So in certain times, the swallowed, whatever the foreign bodies are there, it's like it can be sometimes like sir has emphasized before, it can be sharp objects, it can be button batteries, it can be double magnets. These requires immediate intervention, otherwise they can lead to the bad. So aptly involving other specialties including a medical gastroenterology along with the pediatrics team and the anesthesia team and activating endoscopic facility as well. So aptly helps in removing the foreign body in time and preventing the further complications. And coming to the nose and ear foreign bodies, if it's visible, they try to take it out in the ER. If sometimes it will be difficult to remove, and at times we involve the ENT specialist. So they come at the middle of the time or uncertain times helping in removing the foreign bodies as well. So we don't hesitate to call anyone at any time, and like we call them, they are also don't hesitate to come at all. Sure. So and that's it.
Dr. Pradeep, would you like to talk a little bit about pediatric trauma? I mean, falls and fractures and kids running into things and so on. How is it that parents ought to deal with them at the scene, and then how is it that we deal with them here at the hospital?
Yeah, definitely. See, the kids are very naughty. They run, they jump around, they get... yeah, definitely. They fall around, they play everything, and they sometimes get into serious injuries.
Right.
So treating pediatric trauma is not the same as treating adult trauma. Mm-hmm. So you need to identify the danger signs because they are not able to tell you what happened actually, basically. Right. So sometimes even the parents did not watch what happened. Mm-hmm. So you need to be very attentive. You need to be, you should have expertise in treating pediatric trauma.
Right.
So you need to, there are certain signs where you need to pick out what type of injuries the kid might have had, and you need to act upon. And you need to act fast because they decompensate fast. So at our hospital, we have a special pediatric trauma team consisting of, again, ER physicians, with pediatricians, pediatric surgeons, pediatric anesthesiologists, all these people. So once there is a severe trauma in a pediatric case, so all are activated, we diagnose what is happening, and appropriate interventions are going to help them.
Right.
And I mean, it's not like again Dr. Sindhoora had said, it's not just treating the child, it is even treating the parents. They are very anxious, they're tensed. So stay calm, be patient, and take into the confidence, and explain what is happening. Communication, here communications plays a vital role. So explain what is happening to the kid, and I think they'll definitely support you what is going to happen. Okay.
We have a beautiful pediatric emergency wing. I mean, if you have a chance, you should definitely come see that. Not just as a patient. I mean, it's just a beautiful facility. And with that, I'd go to Dr. Guru. I know you absolutely adore your granddaughter. So I want to talk about the heart behind coming up with this pediatric emergency facility, the kind of facility that we have here at Continental.
Thank you, Venus. It again goes back to my Western experience of several decades. As I said, I graduated and worked in the world's largest medical center, and the Texas Children's Hospital is one of the top 3 or 4 hospitals in the United States of America, and it has now more than 1,000 beds in Houston with all specialties and whatnot. So, being on the faculty, of our hospitals and interacting with colleagues and seeing what happens there and how these things are structured and whatnot, that was, again, my planning for Continental was extremely important. As a matter of fact, Continental is set up for every age and every aspect of humanity, from pediatrics to adolescents to adults and to the geriatric population. Nobody is neglected here at the end of the day. So it was very important. India is a young society. We constantly talk about the demographic dividend, and when you have a young society, there are young children around all the time. So given that, I think we should not do disservice to them. So with that intention and with that plan, we said Continental should have a wonderful pediatric facility. In fact, having a good pediatric facility within a tertiary or a quaternary care hospital makes a lot more sense rather than having an independent children's hospital, because as Dr. Pradeep and Dr. Ravi and Dr. Sindhoora has clearly alluded, these diverse presentations, we never know which specialty is needed.
Right.
Often, standalone hospitals, they do not have all these consultants 24/7. You might have visiting consultants, but the time a visiting consultant, if you're stuck in some other place busy, then you lost that opportunity and the time. So having in a tertiary care institution where all these subspecialties are available to the needs of the children, particularly in an emergency time, is extremely important. As Dr. Pradeep mentioned, we have a beautiful pediatric intensive care unit. We have a neonatal intensive care unit. We have pediatric wards here, and we have created recently. Our pediatric emergency was a part of the adult emergency, but we have now segregated the pediatric emergency both for the comfort of the parents, for the attention to be given to the children. So we have pediatric registrars round the clock. We have pediatric consultants, round the clock who attend to these emergencies and basically take care of these patients. So I am very proud that what Continental could do today in our communities, providing them this door and opportunity 24/7 to take care of their children and giving us the opportunity to provide care to them successfully.
Right. So we are almost at the end of our discussion, and we briefly touched upon obstetrics and gynecology. I mean, there are emergencies we see on a very regular basis. So Dr. Sindhoora, if you can help us understand, what are the common gynec emergencies that we are dealing with and how prepared are we to take care of those?
Any woman of a childbearing age walking to us with a history of severe pain in the abdomen, we always try and evaluate all the possibilities, and ectopic pregnancy and torsion ovary are life-threatening conditions for a woman of childbearing age. And they are promptly diagnosed with the bedside ultrasonographic provision that we have in the emergency room. And it's not an exaggeration, but we have diagnosed most of the ectopic pregnancies even before they could get ruptured. And we've helped them, immediately getting wheeled to the operation theatre for further evaluation, for the management. And not just that, the obstetric emergencies are also very well dealt in our emergency room with the emergency labor kit that we have, with the help of our obstetric and gynecology consultants available round the clock in the hospital.
Right. So friends, we've had a fascinating, wide-ranging discussion on several aspects of emergency medicine. Today, as I've mentioned earlier, is the International Day of Emergency Medicine, and we started talking about what is emergency medicine. We spoke about strokes, cardiac emergencies, gastric emergencies, so on and so forth. We spoke about the pediatrics and obstetrics as well. So as we conclude this discussion, Dr. Arun, any final thoughts from you on emergency medicine here at Continental?
So this year on International Emergency Medicine Day, the theme is Your Safety, Our Priority. It aptly fits into the Continental Emergency Department because your safety being our priority always needs an preparedness, and that preparedness is envisioned by our chairman, Dr. Reddy sir, who has established this department 10 years ahead of time with the world-class facilities. And I have, in the previous discussion, I have forgot to mention about a trauma bay separately constructed in an emergency department, which includes a decontamination zone as well as a modular OT attached to the trauma bay, and an integrated radiology unit is also there in an emergency department, which is not so common in entire India. And this is the vision we have: the emergency cases coming to the emergency department, and we care in crisis.
Right. Any final thoughts from you, Guru sir, before we close today?
I think Venus, you did a wonderful job in asking us very appropriate questions, and I was very proud of the spontaneity of all my colleagues here. And Dr. Arun has very rightly summed up the theme of this year is providing care in a very safe environment. So I think we're very proud of Continental, which has been doing now for the past 1 decade. We're going to continue to improve upon this, and I want to just summarize saying that anything and everything in medicine is a teamwork. Team endeavor is extraordinarily important. It goes beyond the collection of group of doctors to your nurses, which are extremely important. We have not highlighted too much about the nursing care, but typically in the Western world, it's the nurse who runs the emergency department. And in India, it's a different tag here. I think the emergency physician happens to be the team leader. So I think for us all to understand that this is a team effort, team endeavor, and we'll continue to provide safe, prompt, urgent, effective care with outcomes that we should measure and make sure that improvement and quality is our say and our goal. Thank you.
All right, friends, I think with that we conclude this discussion on World Emergency Medicine Day. We thank you for your patience and listening to us. I thank all my panelists for joining me today. Until next time, the only thing I'd like to say is do take care of yourself. Make sure that you can prevent all the emergencies that you can, and if you can't, then we are prepared for all the emergencies that will happen. Until next time, from all of us here at Continental, it's goodbye and thank you.